focus now on an area, bariatric surgery, and really to pick up on that association between mood disorders and obesity. I just want to start off with a show of hands. How many people have treated patients for psychiatric or mental health conditions who have a BMI of 35 or more, so severe obesity? Okay. How many people have treated patients who are considering or have undergone bariatric or weight loss surgery of some sort? Amazing. Like that is remarkable to me, and probably the reason why Roger invited me here, because having given this, presentations on this and learning as the field has evolved, as the research has evolved, if I'd asked this question probably about 7 years ago, I think I may have had maybe 5 people in the audience raise their hand on that second question, which goes to show you that, one, I think there's a greater recognition and awareness of the bidirectional relationship, and two, I think the growing emergence of weight loss treatments, and especially for more severe obesity. And so I'm going to cover that in the next 15 minutes or so. So this is what I'm hoping to cover in the next 15 minutes, an overview of bariatric surgery and psychiatric burden. There have been some key articles and findings that have helped inform what we know and what we still don't know about these relationships. The overarching goal of trying to find predictors of bariatric surgery outcomes, and I'll show you where the psychiatric literature is with respect to that. And then I'll talk a bit about assessment to some practical guidelines that you may walk away with as you're considering and managing patients who are undergoing these weight loss procedures. So I think why obesity surgery, and I alluded to this already, that as patients' BMI starts to increase, the effectiveness of sustainable and durable weight loss treatments, such as diet therapies, have not proven much success thus far. It is a growing field and a field in which there's many treatments still evolving, but really pharmacological treatments have not been the holy grail for obesity thus far. And despite the epidemic and efforts on prevention, especially in children and obesity, we still are faced with this problem in our practice, and you've provided evidence for that. And bariatric surgery has really evolved as one of the few treatments that provides some durable and effective weight loss for patients, although there are needs and supports for these patients, especially from a mental health perspective. So, bariatric surgery is not for everyone, although there are studies underway as bariatric surgery looking at it as a treatment for diabetes as opposed to, say, obesity per se. But these guidelines are the guidelines from 1991 from NIH, which state that if you have a BMI of 35 or higher and an obesity-related comorbidity, you fit the criteria, as well as patients who simply have a BMI of greater than 40. And the treatments for obesity surgery or weight loss surgery have evolved over time, and many people have known about a kind of open surgeries way back when with laparoscopic procedures. The safety as well as the impact for patients has improved over time. We know that there are restrictive and malabsorptive procedures, so the Roux-en-Y is a restrictive and malabsorptive procedure, bypassing kind of that first part of the small intestine and creating a small pouch to get that malabsorption and restrictive components. The sleeve gastrectomy, which is really focused on the greater curvature of the stomach and more of a restrictive procedure, and the laparoscopic band, which has been, again, a more of a reversible procedure, but is not covered by OHIP here in Ontario. And over time, we've seen the slow fallout of the laparoscopic band, which has started to now dwindle in terms of its prevalence, and an increase in the sleeve gastrectomy and the Roux-en-Y is one of the mainstays of treatment. The reason why we've seen these changes is that we see these treatments are quite effective in terms of obesity. The laparoscopic Roux-en-Y gastric bypass, you can see 15-point reductions at 1 year. This is from a large American database of over 300 centers pouring in their data, so real-world data here. And the sleeve gastrectomy is not that far behind. And you see the laparoscopic band showing less favorable results, but still having some effect. And we see the remarkable rates in remissions in obesity-related comorbidities at 1 year, which is why this is being considered as a metabolic type of surgery. You see the diabetes remission rates, and as many of you who have patients who have diabetes and undergo these procedures can see that they may be off their insulin within days after this procedure. So I think the benefits are there, and the benefits for patients as we're talking about comorbidity and mood disorders is also quite impactful. And in terms of the reason why our service and the need for psychiatric care, we know from the data that Roger presented, but as well, if you take a cross-section of patients who are going for bariatric surgery, we see significantly higher rates of psychiatric disorders in patients undergoing bariatric surgery. Now, these studies are a couple in the literature. There's the lab study, which is another one, and a recent meta-analysis that just came out this month in JAMA, looking at psychiatric prevalence rates, but they all seem to show the same thing, and these ones were blinded studies, so they eliminated that response bias in these patient populations. So approximately 60 to 70% lifetime rates of psychiatric illness, predominantly mood disorders, somewhere around 23 to 25% of patients having active mood disorders, followed by eating disorders, mainly binge eating disorders, and anxiety disorders. And I would insert in there, as we think about other phenomenon, trauma as well, about 40% or higher having significant trauma histories. So you're seeing a significant burden here compared to the general population. And again, a reason why there's a role to study, understand, and try to help patients in their treatment of severe obesity. This is looking at their psychiatric illness course after surgery. This is from the lab study. Melissa Kalarchian from Pittsburgh and her group looked at this data and showed, again, reductions in psychiatric disorders at their follow-up appointments after weight loss surgery up to 3 years. We do see, though, some trends, some emergence of mood disorders later on, and I'll allude to that further in the next few slides. But again, overall benefits, but again, there is some persistence of psychiatric burden afterwards. When we think about assessment, these are one of the reasons why psychiatrists and mental health professionals have been involved. Over a decade ago now, nearly 15 years ago, when the survey was done, was a survey of all bariatric centers in the United States and asking individuals doing assessment, what are the reasons why patients should not go for surgery in terms of mental health conditions, largely focused on substance use, psychosis, and mental retardation, particularly around adherence and ability to make capable decisions regarding the treatments. We see over time that this has started to shift, and I'm going to show you some data in terms of outcomes that have helped expand the inclusion criteria for bariatric surgery. So this is some work looking at bipolar disorder, and again, outcomes. And I know, Roger, you were part of the second study there looking at outcomes in terms of bipolar patients. But this is looking at patients pre-surgery and up to 1 year post-surgery, and divided them into patients with bipolar disorder, other psychiatric illness, or a control group. And what they found here is no significant difference in weight loss, which is the primary measure of outcomes in terms of these studies. And an additional study looking at 144 bipolar patients, looking at their service utilization afterwards, showed no difference in terms of psychiatric hospitalizations or emergency room visits up to a mean of 2 years post-surgery. So again, surgery can be safely delivered to patients with significant psychiatric comorbidities and mood disorders, and in this case, bipolar disorder. These are some of the psychosocial contraindications to bariatric surgery. Again, substance use for a couple of reasons. One, due to safety reasons, because alcohol and nicotine use can result in ulcerations at the anastomosis, which can be significant complications. I will show you some concerns after surgery regarding substance use. Obviously, severe eating disorders, particularly bulimia or purging behavior, although you'll notice not binge eating disorder, because there are some studies that have shown some favorable effects with bariatric surgery, either due to the surgery or the interventions related to surgery. Adherence being one of the issues, but also stable psychiatric illness as defined through the Ministry of Health and Ontario Bariatric Network about stability within the last year. And again, this is mainly because of the reason of a high significant psychiatric comorbidity and concerns after surgery, and I will talk about some of the concerns that you may have heard about in the news. So here's the challenge. So most of the assessments are done in centers around the province, although as patients are considering this is something to consider pre-surgery, but most of our work is really around the post-surgery phase. And so this is data from our ongoing quality database looking at psychiatric outcomes afterwards, and we generally see that patients do quite well in that first year, but we do see some relapse, so to speak, of some of the mood and anxiety symptoms, and we see that mental health or mental health quality of life is really not significantly different after surgery, and that would be predominantly related to the high psychiatric burden and the ongoing need for psychiatric treatment in our patients after surgery. This is another study, again, from the labs group that looked at outcomes. And again, you see significant improvements in that first year, but we do see depressive symptoms starting to creep back, as well as some changes in weight over time. And although here it's quite stable, there are some longer-term studies that have shown some weight regain related to the relapse of depression. If you look at potential complications, I think our major complications that we have to think about from a psychiatric and mental health perspective are related to kind of what would I consider self and other disturbances, psychiatric illness and disorders, and then severe mental health sequelae. So there's been some work looking at relationships, and we know that difficulties in relationship before bariatric surgery are often exacerbated after surgery with the transitions of weight loss, changes in family unit when one individual is losing a significant amount of weight. I'll speak to body image concerns, but you can imagine when someone's losing significant amounts of weight, the impact on their self-image and then the impact of excess skin folds. There are some reports of kind of cross-addiction that have emerged in the literature, and I'll talk a bit about alcohol. Psychiatric disorders, there are some patients who develop new onset psychiatric disorders afterwards, again related to likely some of the stressors afterwards, but there are some additional complications. And we also see new eating disorders, and I'll talk a bit about, again, thinking of a dimensional approach rather than looking at binge eating disorder as one whole disorder, but this disinhibition and impulsivity spectrum, which relates to some of these maladaptive behaviors and other substance use. And many of you have probably heard about the higher rates of suicide and self-harm in bariatric surgery patients. There's a JAMA surgery paper that just came out last year from the Ontario ISIS database, a horrible name, but the Institute for Clinical Evaluative Sciences, which actually showed higher self-harm incidence after surgery in an Ontario patient population after controlling for various psychiatric variables. So again, a concern, again, in terms of long-term follow-up. This is an interesting study from the Swedish obesity study, and there's been replicated studies that have looked at alcohol use. And so after bariatric surgery, we know that patients' absorption of alcohol changes dramatically. So patients can get intoxicated on one drink of alcohol, exceeding the intoxication threshold, and it can take them substantially longer to metabolize alcohol afterwards. And for some patients, there's about 7 or 8% of patients that develop new onset alcohol use disorders after bariatric surgery. We know that this is a higher risk for certain procedures, and the Roux-en-Y gastric bypass is one that has been shown to have a higher risk in terms of alcohol use disorders. So again, something we screen for in our patients, but again, it's also along that spectrum and dimension of impulsivity. This is a study that we looked at body contouring. So many of our patients have excess skin folds after surgery that are not covered by health insurance plans. And as a result, this can add to significant distress. It's been one of the hypotheses for kind of a risk after bariatric surgery. And we showed that for patients who had the means to undergo body contouring, that it had significant improvements and improvements in mental health related quality of life as well. So I think with these risks after surgeries, the holy grail for many bariatric surgery programs and obesity treatment programs is to predict which patients, and particularly the psychosocial predictors, given their burden and chronicity, which ones are likely to predict outcomes. And unfortunately, after probably billions of dollars of research, we're still left with many questions in terms of predictors. And partly that's related to blurring what might be those target outcomes. And if you ask 100 patients who are undergoing weight loss surgery or even weight loss what their definition of success is, you will get different answers. It can range to that many do default to the weight on the scale, but many are also related to, are thinking about their physical comorbidities, their psychiatric symptoms and their mood, self-esteem, as well as overall quality of life. And so it's important to identify what those target outcomes are. We've conducted a review, and many others now have conducted reviews. And again, the JAMA article that just came out a couple weeks ago looked at pre-surgery predictors and really replicated this previous work as well, and showed that really there are a few signals, I would say, as predictors of weight loss outcomes. And many of those are behavioral related, as well as related to complexity and high psychiatric comorbidity and lack of supports and resiliency factors that might help protect against some of these factors. What I will say, though, is many of the preoperative predictors have not been as robust, and in fact, most of the work is related to postoperative factors like loss of control over eating after surgery, disinhibition, or exacerbation of mood disorders. This is a slide from the Swedish obesity study, again, a 10-year cohort study looking at different types of weight loss surgery compared to medical treatment for obesity. That's the conventional treatment. And what they showed was that there were reductions overall in eating behaviors on these dimensional scales looking at restraint, disinhibition, and hunger. But what they ended up finding when they looked at those who regained weight or had insufficient weight loss in this study, that surgery was not equally effective, and in fact, those who regained weight had less improvement in disinhibition and hunger in that first year. And so this has been a useful approach, and much of the literature and research on interventions has really focused on treatment post-surgery and that early kind of high-risk vulnerability period. And I would say that's where probably the most of the research is heading in terms of bariatric surgery and outcomes. We do see, again, this honeymoon effect in that first year in terms of people doing well, reductions in depressive symptoms, but again, that creep effect that happens beyond that 12-month period, and again, which further supports the need for further interventions in this area. So this is the holy grail, right? We're looking for this will never come to Toronto in the near future, I guess, but I guess we can keep hoping. So one of the things we're looking at is we are looking at tools to at least standardize our assessment. So a colleague of mine, Rad Hawa, and I have coined the BIPASS tool, which will be is going to be launched once we are finished our cohort study looking at predictive outcomes. Has shown some good inter-rater reliability, and it's an interprofessional tool because one of the flaws of previous predictive tools, it was reliant on a single cross-sectional assessment, and having a multiple professional see a patient is probably the most valuable, most reliable indicator of patients' kind of vulnerability to certain risk factors. So we're looking at this as a potential tool to look at outcomes. I would say we are also looking at, there's a range of treatments we've been exploring, including mindfulness. There are protocols called mindfulness-based eating awareness therapy, which is used for binge eating, which is being used in bariatric surgery patients in group settings, as well as a couple of our telephone and online CBT interventions, which have shown some signals. Again, the goal is, I think, post-operative focus and a stepped care approach, which is, I think, key in terms of addressing eating pathology that's often linked into these mood symptoms. So, this is an example of our program, which is really, we have the fortune of having a comprehensive program where patients undergo a series of assessments and have access to post-operative follow-up. So our patients can enter our mindfulness groups if they've been through our program, as well as getting some of our online resources or in-person or telephone-based CBT. Just to end with medications, I often get questions about medications. As you see the psychiatric comorbidity, about 40% of patients coming for bariatric surgery are on antidepressants alone. If you throw in all psychiatric medications, even higher. And about anywhere from 25 to 30% at 2 years will remain on those psychiatric medications. So this is an in vitro study looking at dissolution rates. So they created the same pH as a Roux-en-Y gastric bypass and showed that what medications might be vulnerable. Some of the antidepressants there that might take longer to dissolve, clonazepam, as well as some of the atypical antipsychotics. Lithium, however, had an increased absorption due to the pH changes, right? Being a more basic type of medication. And there are some smaller studies looking at absorption after surgery, and basically has shown that that first 6 months and 12 months after surgery is a high-risk period for reduced absorption. So monitoring is essential, switching from extended release, which are difficult to break down. And we do have cases of lithium toxicity in the literature and in some of our patients, which have resulted in protocols to help guide our patients. So in summary, I would say that bariatric surgery is an evolving, durable treatment. There are a number of risk factors, but we do need to intervene in a way that's really focused on postoperative care and support for our patients, both in the short term and long term. And so there are some resources if you're interested in terms of some of the protocols as well. So thank you.